So in this voiceover on birth, we're going to cover several topics, including the signs of labor, the 5 P's of labor, mechanisms and stages of labor, pain management, both pharmacologic and non-pharmacologic, C-section deliveries, and maternal obesity. There'll be another voiceover that will discuss maternal and fetal complications during birth, and another for fetal heart rate assessment. The intrapartum period begins with the onset of regular uterine contractions and lasts until the placenta has been delivered. This time period is typically referred to as labor. Everyone wants to know when they will go into labor. And what causes a woman to go into labor? Well, that's not totally understood, but there's theories that involve both maternal and fetal factors. However, there are known signs that indicate that a woman's body is preparing for labor. These signs include lightening, which is the descent of the fetus into the pelvis, and this happens about 2 weeks prior to term in first-time moms. Braxton Hicks contractions, also known as practice contractions. These are irregular contractions that do not cause cervical change. They're associated with false labor. Then you get cervical change. The cervix begins to ripen, which means it starts to get softer, it starts to thin out, and maybe open up a bit. And because of that, the mother might lose her mucus plug. Nesting is another behavior that can signal impending labor, and this is when a woman experiences a burst of energy before labor and starts trying to get things in order, make sure the crib's ready, got all the clothes ready, diapers, wipes, all that stuff is in order. Women also might get a bloody show, and this is a brownish or blood-tinged cervical mucus discharge, typically associated with dilation. This bloody show sometimes includes the mucus plug mentioned previously. Women with those signs of impending labor also complain of low backache and sacroiliac discomfort, and this is usually due to relaxation of the pelvic joints. Some women, not all, do lose 1 to 3 pounds before labor begins. And then there's also the appearance of GI symptoms like nausea, diarrhea, and indigestion. Now, the 5 P's of labor are factors that have been identified as essential components of a successful labor and delivery. And this includes the powers, the contraction, the passage, the birth canal, the passenger, the fetus, the psyche of the mom, and position of the mother in order to facilitate birth. When we're talking about powers, we're basically talking about uterine contractions. And the job of uterine contractions are to dilate and efface the cervix. Now, dilate means for it to open. Effacement is the thinning of the cervix. Uterine contractions are described according to their frequency, duration, and intensity, and can be mild, moderate, or strong. When we're talking about passage, we're talking about the pelvis and the birth canal. And first off, no matter how a woman looks on the outside, it doesn't determine what their pelvic outlet looks like. There are 4 types of pelvises, as you can see in the diagram. The normal female pelvis type is the gynecoid pelvis, and its pelvic inlet has a rounded oval shape and a wide transverse diameter. And this is the best passageway for the fetus. There are android and anthropoid pelvises that are most common in males. Women with android pelvises have a harder time delivering, especially larger babies, but can deliver the smaller babies without difficulty. Anthropoid pelvises tend to favor occiput posterior presentation, which is a difficult labor. And then platypoid pelvises are rare, and due to the narrow inlet, the fetuses have a tendency to end up being transverse instead of head down, and will end up not being able to be delivered vaginally. The fetus and the placenta are the passengers, although the primary passenger is really the fetus. The size of the fetal head, fetal presentation, fetal lie, fetal attitude, and fetal position greatly affect whether the fetus will be able to navigate the birth canal. Nursing care during the intrapartum period addresses not only the physical aspects of care, but also the large psychological component. This will ultimately impact the woman's wellness and satisfaction with the labor process. The state of the mother's psyche is crucial during childbirth. And culture can play a large part in a woman's reaction to labor expectations and how she interacts with others. Cultural sensitivity is very important because it impacts who is with the woman in labor, what their role is, and who participates in decision making. Additionally, culture plays a role in medication preference, her feelings toward those of other genders, modesty, and obviously her response to labor in general. And the last P is position. The postures and the positions of the mother during labor and birth. Now, the medical model has mom laying on her back in that lithotomy position with their legs up in stirrups, and that is like almost the worst possible way to give birth. The mother needs to take advantage of alternating positions, moving around, using gravity to help move the fetus down. So standing, walking, sitting in chairs, squatting, birthing balls, even side-lying positions are much more beneficial. Now, sometimes position is limited, especially with women who choose epidurals because their lower body is numbed up. They can't move around as well, so they are sort of restricted to movements in the bed. So you have to take into consideration what type of pain relief measures the client is using as to what movements and positionings are best for that client. So there are certain positional changes that the fetus must make during labor and delivery, and these are called mechanisms of labor or the cardinal movements of labor, and they involve engagement, descent, flexion, internal rotation, extension, restitution, and expulsion. The graphic on the slide gives you a good sense of each of those phases happening during the delivery of that newborn. So there are 4 stages of labor, and the first stage is divided into 3 phases: latent phase, active phase, transitional phase. This first stage of labor begins with the onset of regular contractions and ends with complete dilation. The second stage is the delivery of the fetus. The third stage is the delivery of the placenta after the fetus is born. And then the fourth stage begins after the delivery of the placenta and continues for 1 to 4 hours after delivery. So the first stage of labor begins with the onset of true labor and ends with complete cervical dilation. Typically, it's the longest stage, and there's a large variation in the amount of time individuals will process through this first stage, especially first-time mothers or prima gravidas, versus women who have had children before, multigravidas. They'll proceed through the first stage of labor more quickly. Now, like I mentioned on the previous slide, the first stage is divided into 3 phases. The latent phase is the beginning of labor, and it's about 0 to 4 centimeters of dilation and 0 to 40% of effacement. It's a great time for education because mom is still feeling pretty good during this phase, and some women actually choose to labor at home. During this phase, the women are able to focus on themselves, labor, and birth. Emotions vary depending on the individual and can range from excited to anxious to relief. As far as pain management, non-pharmacological pain management methods tend to work better during the latent phase, walking around, distraction, position changes. As nurses, you will focus on getting the admission record completed, which includes the history and physical, in addition to assessing the fetal heart rate and reviewing the woman's childbirth plan if she has one. And then you also are going to be checking for GBS status to find out if it is positive, because then you'll need to start antibiotic prophylaxis. The active phase of the first stage is when when labor starts to get real. Active labor is typically defined as a cervix of 6 centimeters, but it lasts around until 7 centimeters with an effacement continuing to about an 80% effaced cervix, and the fetal descent is continuing. Fatigue starts to set in, and the women get more focused with each contraction. So the discomfort and the pain worsens, and many women will request pain meds at this point. So if she's not already at a hospital or birth center, she'll likely present at this point. As a nurse, she'll continue to monitor the fetus and the uterine contractions. You'll be providing a lot of emotional support and helping the woman through the contractions. Between contractions, the focus should be rest and attending to hygiene, including peri-care and changing the chuck pads underneath the patient. The transition phase is the most difficult, but thankfully it's the shortest. The cervix opens completely to 10 centimeters and becomes 100% effaced, like paper thin. There's an increased bloody show. The classic signs of the transition phase are that the woman starts getting more irritable. She starts doubting that she can do this. I can't cope anymore. She starts shaking and diaphoresing. The second stage of labor begins with complete dilation of the cervix and ends with the delivery of the baby. Many women experience a burst of energy, become more focused, and feel ready to actively participate in pushing efforts. During this time as the nurse, you're coaching the woman on how to bear down and to push with the urge and to rest between contractions. You're keeping an eye on the fetal monitor, maybe making sure that the fetus is tolerating this birthing process. And you're also providing comfort and emotional support. So the third stage of labor begins after the delivery of the baby and ends with delivery of the placenta. Active management of the third stage helps to decrease the risk of postpartum hemorrhage. Following delivery of the placenta, the delivering provider should inspect it for completeness and anomalies. The nurse's role during the third stage includes administering the uterotonic meds as ordered. This is usually the oxytocin. And then there's close monitoring of the maternal vital signs and fundus every 15 minutes, massaging, making sure the fundus is firm, and that there's not too much bleeding going on. During the fourth stage of labor, which is the immediate postpartum period, this is defined as the period after the delivery of the placenta through 4 hours postpartum, the time that the mother is stabilized. Any lacerations or episiotomies that occurred during birth would be repaired by the provider. Nurses are making close assessments on that fundus, again, massaging the fundus, making sure it's nice and firm. So there are many examples of non-pharmacologic pain management used during labor and delivery. And these are strategies that help prepare women, help manage the discomfort, and promote relaxation. The gate control theory of pain states that sensation of pain is transmitted from the periphery of the body along ascending nerve pathways to the brain. All right, so this theory is that there are only so many sensations that can travel this pathway at once. So if you perform an alternate activity that can replace the pain sensation, then you can reduce the pain impulses from reaching the brain. Now, Prior to initiating any sort of pharmacological pain management, the nurse has got to do a pain assessment. A pain assessment includes the intensity, location, pattern, degree of distress, and of course having the mother rate her pain on a scale from 1 to 10. So the pharmacologic pain management in labor falls into two categories: analgesics and anesthesia. Analgesic options include opioids. Now, as we discussed in the pain lecture, opioids are not without potential side effects, and it's important that mother and fetus are monitored because opioids cross the placenta and can cause neonatal respiratory depression, especially if given within an hour of birth. Anesthesia includes local, regional, and general anesthesia. Now, local they use sometimes after delivery to repair episiotomies or lacerations. The regional anesthesia is what would be used during the labor. This would be your epidurals. For those who are undergoing a planned C-section, you can use spinal. And general anesthesia is usually reserved for emergency C-sections. So sometimes a vaginal delivery is just not possible. Think back to the placenta previous. They cannot be delivered vaginally. So along with medical reasons, you could have bad fetal heart rate strips necessitating an urgent or emergent delivery. You could have moms with previous spinal surgery who can't labor and deliver the child vaginally. There are a number of reasons. C-sections are classified basically along the lines of these reasons. So when it's scheduled, a scheduled C-section occurs prior to the onset of labor. This was me with my second. First one ended up being a C-section, so the second one I was like, nope, cut along the dotted line, and we were told be at the hospital at noon for delivery by 1. An emergency indicates an immediate need for delivery, and this is an event of a cord prolapse or uterine rupture. Now, an urgent need is when you need a rapid delivery, especially if the baby is breech. Then finally, there's non-urgent C-sections, which indicates that there's a reason for the C-section delivery, but it's likely associated with the failure of the cervix to dilate or the baby to descend into the pelvis. Now, in the event of a C-section, the role of the nurse goes from, instead of being just the plain old labor and delivery nurse, you're now the perioperative perinatal nurse, because you have to now combining your obstetric skills with some surgical and post-anesthesia care. So you're the pre-op nurse, you're the intraoperative nurse, usually the circulator, sometimes the scrub nurse, and then you'll act as the PACU nurse till you're ready to transfer the patient over to the postpartum unit. So lastly, I want to address maternal obesity and its impact on labor. Now, it's a lot harder to monitor the fetus with a woman who's obese because you can't find the proper places or good places for conduction of the sound for the ultrasound probe. You'll have larger babies, you have risks for shoulder dystocia, the shoulders getting stuck as on the way out. You've got higher rates of operative vaginal delivery, which includes using forceps or vacuum. You get an increased risk of hemorrhage and an increased risk of postoperative complications. So on top of all your normal assessments, you want to be proactive, anticipating that there might be more complications with this birth, that you might need more staff, special bed. You're going to have to make sure all the equipment is appropriate based for the client's weight and provide sensitive and empathetic care to the client as she goes through the labor and delivery process. That brings us to the end of this voiceover. As always, if you have any questions, please email me. And if you haven't already done so, please review the voiceovers on fetal heart rate assessment and birth complications.